Yes.
Yes, there we go. Okay, I'm going to mute our system and you can start us off. Thank you.
Thank you. Good morning, everyone. My name is Dr. Hussein Mahadhi from University of the Free State. And this morning debate, I'm going to explore the topic of vasectomy as a temporary contraceptive method. So I'll begin by discussing the broader context of contraception and exploring the various contraceptive available options in men. And then from there, we'll dive into specific of vasectomy, covering its anatomy, surgical techniques, and the important aspect of vasectomy reversal. Along the way, we will review the context literature to provide the comprehensive understanding of the success rates and the considerations surrounding the vasectomy reversal. And then by the end of the discussion, we will have a clear picture of why vasectomy is a viable option for temporary contraception. So by introduction, can you hear me?
Yeah, we can hear you perfectly. If you can, is it possible for you to make your slides full screen? I think at the bottom there.
Yes.
Yeah,
Yes.
There we go. Thank you.
All right, good. By introduction, birth control is not just a woman's responsibility. By discussing vasectomy today, it reminds us birth control is not just a responsibility of women, it is a shared responsibility between the partners. By acknowledging this, we promote equality in contraception and empower couples to make choices better. And we have to remember there are females who have challenging to the contraceptive options because of the healthy conditions or side effects. Therefore, we're highlighting the need for a range of other contraceptive options. By definition, as we know, contraception is a method of or devices used to prevent pregnancy. We're going to concentrate on contraceptive methods for men, which include condoms, which are the barriers and the very common method that prevents sperm from entering the woman's body. It can also prevent STDs. The next, the vasectomy, which is a surgical procedure where the vas deferens is blocked to prevent sperm from reaching the semen. And then withdraw this coitus interruptions, and then hormonal methods, which are still in development. These are injections or implants that inhibit sperm production. In terms of effectiveness, vasectomy out of those 4 methods available is the most effective method of contraception, which has less than 1% chance of pregnancy after the procedure. I would like to take you in 30 seconds about the historical background of vasectomy. So early rules of vasectomy started in ancient Greeks, whereby they used crude method for male sterilization. The technique used was cauterization and ligation of the vas deferens. And then from there, then we went to early modern development in the 18th and 19th century, where we saw limited advancement of the surgical technique. And then it transitioned to modern era, and it came to the recognition in mid-20th century, whereby it was considered as a safe contraceptive option. So regarding the benefits of vasectomy, it is simple and cheap, and works better than female sterilization. And the patient can go home the same day of the surgery. It doesn't change the way sex or ejaculate feels, and the semen doesn't look, smell, or feel any different. Overview of procedure and surgical technique. We start with the physical history taking and physical examination, then anesthesia. The recommended mode of anesthesia is a local anesthetic, and this is the technique. We're advancing the needle parallel to the vas with the within the external spermatic fascia, sheath toward the inguinal ring. Then vas isolation. This should be performed using minimally invasive technique, such as no-scalpel vasectomy, compared to the conventional method, which show the low risk of postoperative complication like hematoma, infection, compared to the conventional method. And then mucosal cautery. This is it has lower risk of failure compared to fashion deposition. Then postoperative vasectomy testing. You can see here, if it is azoospermic, then we can abandon less than 100, we can abandon the contraception. If it is more than 100 immortal, then we can redo the vasectomy. Now, coming to our talk now. Can vasectomies be considered as temporary contraception? So my response is yes. So it is estimated about 6% of men worldwide who undergo vasectomy will ultimately seek vasectomy reversal. So in the era of improving assisted reproductive technology, the patient with previous vasectomy who are requesting fertility have only two options. Either they do vasal repair, which include vasectomy reversal or vasopedidiectomy, or testicular sperm extraction with intracytoplasmic sperm injection. And out of this, the vasal repair, which include the vasovasectomy, is the only option that leads to natural conception. So as we know, this vasectomy reversal is a surgical procedure that reconnects the vas difference, allowing the restoration of the flow of the sperm for fertility purpose. There are two primary types of vasectomy: the vasovasectomy, which is the most common type of vasectomy reversal, and the vasopedidiectomy. This is more complex and specialized type of vasectomy reversal. It is performed when there is a blockage or scarring in the epididymis. The common reason for undergoing vasectomy reversal is when the individual has undergone previous vasectomy and now seek restoration of fertility, changes in personal circumstances or relationship may prompt the individual to reconsider their reproductive choices, and post-vasectomy pain syndrome. These are the factors which influencing the success rate: preoperative, obstructive interval, prior fertility, prior inguinal surgery, prior vasectomy reversal, and the partner age. Intraoperative, surgical skills, surgeon skills, intravasal fluid, testicular sperm, testicular remnant length, sperm granuloma, and vasectomy location gap. Vasovasectomy, we have macrosurgery and we have microsurgery. It's a two-layer technique, which is preferred method of anastomosis, which begins with 9-0 nylon sutures through the muscular layer, followed by 10-0 at the mucosal layer. And then vasopedidiectomy, whenever there is unsuccessfulness of vasectomy, or if the vasectomy site is in the lower part of the vas, then in this case, it is indicated to do vasopedidiectomy for vasectomy reversal. Now, my arguments on this debate will focus on 4 points: the surgical technique, cost effectiveness, obstructive interval, and the female age. Starting with the surgical technique. So vasectomy can be done successfully with microsurgical technique. It can also be done macroscopically, although the patency rate and the pregnancy rate is lower compared to microsurgical technique. This is the study which was published in 2023, the systematic review and meta-analysis, which was done by Ithiki and his colleagues. So they compare the three vasovasectomy options, whether we do macroscopic, or robotic assisted microscopic. And they found the success rate, the patency rate, and the pregnancy rate was high in microscopic, and was high in robotic, followed by macroscopic, and then macroscopic. So if you see this data here, microsurgical technique is 87.5%, macroscopic is 83.7%. It's not that big difference between macroscopic and microscopic. So we can still use macroscopic for vasectomy reversal. This is a EUA guideline. They recommend to perform microscopic vasectomy or epididymal vasectomy. Now, the second argument, there are a lot of arguments about obstructive interval. So if you look on the vasectomy study groups, which were done more than 30 years ago, so they show that there was a consistent drop in the patency rate and the pregnancy rate after 10 years of obstructive interval. Recent data suggests obstructive interval is less important in terms of patency and pregnancy rate than early study. The technical advances and experience have no doubt influenced the improved surgical outcomes in vasectomy reversal. we have several studies which demonstrated the patency rate close to 90%, which can be achieved even with extended obstructive interval as long as at least one vasectomy is performed as part of the repair. This was a study which was done in 2014. They compared the outcomes of vasectomy. They were checking the vasectomy reversal outcomes in terms of obstructive interval greater than 10 years, and they found that more than 90% pregnancy rate was found with the obstructive interval more than 10 years. So this debate now, we have the answers now. Obstructive interval is not that much important. This is another study which was done by Stephen Bojan and his colleagues, and then they also found the patency rate of more than 90%, less than 5, and then 10 to 15 years, the patency rate about 89%, which is quite high. The third argument is about the female age. There were arguments that the female age influenced the success and the outcomes of a vasectomy reversal. If you look on this was the study which was performed by comparing different surgical techniques and the age of the female. If you look here, the female age 35 to 37, this vasectomy is about 85%, and the female age 38 to 40 is 82. Still, there is a good success rate of the vasectomy reversal. Even with more than 40 years, we still have the success rate of 54% with vasectomy technique. Another study, this was done compared. Yeah, this is the one which comparing the age. So this study was done by Akash and his colleague. The objective was to provide to check the live base in female partners of age more than 35 years, and then they found vasectomy reversal is strongly recommended even with the female age more than 35, and carefully in selected patient with the age of more than 40 years can also be done. The other argument is about cost effectiveness. As I have mentioned earlier, that we have two options in this era of assisted reproductive technique. Either we do vasectomy reversal or we do sperm extraction with in vitro fertilization. This study was done by Justin and his colleague, and then they compare the cost effectiveness, and they found that the vasectomy reversal is more cost effective compared to in vitro fertilization for the men who seek fertility after obstruction. So conclusion, vasectomy can be used as a temporary contraceptive method since it can be reversed with a good outcomes and high success rate. Thank you very much.
Thank you very much for that, Dr. Mahadhi. That was an excellent talk, straight to the point, and I think you argued your points well. I think before we open the floor to any questions, we'll move on to our next talk, and then I think we'll save all our questions for both speakers at the end. Right, do we have Dr. Chacha available?
Good morning, Dr. Opel.
Morning, Dr. Chacha. How are you?
Well, thank you. Sorry, I'm just going to quickly share my screen. Can you see my screen?
Yes, we can see your screen. You can just make it full screen and then
I'll do that. Just there we go. Is that fine?
perfect. You can take us away.
Thank you. Good morning, colleagues. I'm here to tell you why we should not be considering vasectomy as a temporary contraception. So these are my reasons why it should not be considered a temporary contraception. Vasectomy is a surgical procedure. It is invasive and has complications. There are temporary male contraceptive methods that are available that are effective and less invasive. Vasectomy reversal procedures are not 100% successful, and they come at prohibitive costs. They require special equipment and they require theater time, and there is a learning curve associated with them. And it's important to note that patency of the vas does not equal pregnancy. Complications of vasectomy, as I said, it is usually bleeding. You can have a hematoma which appears shortly post-op. The patient can have infection which is usually mild, limited to the incision site. There are, however, cases of Fournier's gangrene and endocarditis post-op. And there is a case where death has been reported from Fournier's gangrene post-vasectomy. You do have, patients can have post-vasectomy pain syndrome. It is usually light, but it may require surgical management, which ranges from resection of palpable nodules, and sometimes you may need to do denervation of the spermatic cord or even do a achidectomy for the patient. It's important to note that sometimes this pain persists in some patients despite surgical intervention. You can get a sperm granuloma, which is usually secondary to infiltration of the germ cells into the epididymal stroma. This is usually asymptomatic, but it may play a role in vasectomy failure and post-vasectomy pain syndrome. And of course, vasectomy as a procedure can fail, and persistence of motile sperm after 6 months warrants repeat surgery. The anesthetics colleagues from Columbia wrote this paper to remind us that not all vasectomies can be performed under local anesthesia. And the patients that would require GA are probably because you are anticipating difficulty palpating the vas, and this is usually in patients that have high BMI. These patients poses difficult airway and ventilation management for anesthesia. In terms of alternatives, we cannot speak contraception in South Africa, a country that has about 7.5 million HIV positive people, and not speak about prevention of HIV and STI spread. The male condom, therefore, should be the temporary contraception that we are all championing. It is effective up to 98% when used correctly. As I said, it does protect your patient from STIs, including the HIV. There are no real side effects to the condom, and there are latex-free condoms available for those who have latex sensitivity. You get immediate return of fertility as soon as you stop using condoms. And in South Africa, condoms are available free of charge and almost everywhere. Now, if you cannot use condoms, your option would be abstinence. If counseling is done in a sensitive and that non-judgmental manner, this could be an acceptable form of contraception. It is the most effective contraception. It doesn't affect fertility. Unfortunately, unlike the condom, it doesn't prevent the spread of HIV and STIs. It is important for us to encourage delaying sexual debut for young people, and hugging, kissing, and body rubbing to show affection is allowed in abstinence. In terms of the oldest form of contraception, coitus interruptus, its effectivity is around 73%. And again, your fertility is not affected once you stop using this form of contraception. So I've put these three in this order as order of preference, as our gold prize would be encouraging the use of condoms. So what is on the horizon for us? There are a couple of studies that are currently ongoing in male contraception. If this proved to be successful and safe and effective, we would end up with options of injectables and combination gels and oral medication that brings the options for men in line with options for female patients when it comes to contraceptive options. Now, Dr. Hussein already touched on the fact that about 6% of patients currently would require a vasectomy reversal at some point. So this study looked at whether if you do a vasectomy in childless men, the vasectomy regret is higher than in the population of men that already have children. And this showed that the vasectomy regret rate is at about 7.4%. So that's still within the 6 to 10% that is quoted in other literatures regarding the need for vasectomy reversal. This shows that the population that would require vasectomy reversal is not that big, and we will get to why the number of operations is important later. In terms of reversal, you have an option of vasovasostomy or epididymal vasostomy as your surgical procedure. The vasovasostomy requires patent proximal and distal limbs of the vas. If the obstructed proximal limb, if there is obstructed proximal limb or there is long obstructive time, epididymal vasostomy might be indicated in those patients. And epididymal vasostomy is more technically demanding. These vasectomy reversal procedures require general anesthesia and spinal anesthesia, which basically means you're going to require theater time. And I think everyone in the audience understands the pressures that we are under when it comes to theater time for elective cases. It is important to note that any surgeon offering vasectomy reversal should be able to do both vasovasostomy and also epididymal vasostomy, because the decision to do one or the other basically should be taken intra-op. If it's not possible to do the vasovasostomy, you should be able to proceed to do the epididymal vasostomy. Dr. Hussein has already alluded to the fact that using the microscope improves outcomes. So there is better patency with the use of the microscope than doing vasectomy reversal without it. What he may have not mentioned is that it takes much longer to do a vasectomy reversal with the microscope, about 106 minutes versus 78 minutes without. And we know that there is a learning curve to using the microscope. And in the USA, they talk about, and in literature, they talk about the fact that the surgeons that have higher volumes of vasectomy reversals tend to have better outcomes. And to be in the top 10% of surgeons that are doing vasectomy reversals in the USA, which has the highest number of vasectomy reversal, would mean that you are doing about 11 reversals a year. So really, this is not a crisis that we need to find a solution to. In terms of outcomes of vasovasostomy, this was a meta-analysis and systematic review where the overall post-operative patency was about 89.4% and the pregnancy rates at 73%. This was looking at 31 studies that were done between 1980 and 2014. The problem with these studies was that the definition of what patency is ranged from presence of a motile sperm to presence of 20 million motile sperms. So there's also not clear definition of what is meant by pregnancy in most of these studies. There was only one study in this meta-analysis that reported on whether patients had natural conception rather, or they had assisted reproduction. In terms of epididymal vasostomy, this was another meta-analysis and systematic review that was that came out in 2019. There were 42 studies that they looked at between 1978 and 2017, with about 2,298 participants, and the cohort sizes between 6 and 249. The results showed that patency is even lower with epididymal vasostomy, and it's sitting at 64.1% with pregnancy rates of 31.1%. Again, there was heterogeneity in definitions of what patency is and what pregnancy is. Now, vasectomy reversal also comes with complications that are similar to vasectomy. And we need to also note that the return of sperm to ejaculate is not immediate. It's about 1.7 to 4.3 months for vasovasostomy, and 2.8 to 6.6 months for vasoepididymostomy. There are cases where there is delayed return of sperm to ejaculate for about a year or two. And this is important because we do know that female partners have a reproductive window that we need to be cognizant of. The vasectomy reversal failure, it can happen, and in the early stages it might be because the surgeon did not recognize upstream obstruction, but it can also occur later on, secondary to stenosis at the anastomotic site, or it could be secondary to infections. This can happen between 6 and 14 months, and up to 12% of patients who had vasovasostomy and up to 50% of patients who had vasoepididymostomies may have late vasectomy reversal failure. In terms of costs, definitely, as Dr. Hussein had mentioned, vasectomy reversals are much more cost-effective compared to assisted reproduction. However, cost effectiveness is relative. This was a paper looking at the reported cost on websites of multiple surgeons in multiple states in America who advertise vasectomy reversals as some of the services that they offer. And you will see that it ranges from $1,990 to $14,175 US, which by no means is cheap. And most medical aids would probably not carry such costs on behalf of the patient, and this may unfortunately be an out-of-pocket expense. Now, once vasectomy has failed, what then? If your patient is still insistent on natural conception, you would then consider redoing the vasectomy reversal. And the numbers that are coming out of literature, Belka in 91 showed spermatozoa in 75% of these patients. Hernandez, in his 33 patients, there was 79% patency. Peck showed 92% patency, and the most recent paper, which came from Lorenzini and colleagues in 2021, showed that the patency rate of the 18 patients that they did was 66.67%. And of that, if you break it down, only 50% had normospermia. The 16.67% had oligozoospermia. Again, after redo of the reversal procedures, there is also still late failure rate, which now for vasostomies, it's 27%, and for vasoepididymostomies is about 18%. If your patient is not wanting natural conception because of maternal age or because of other reasons that they do not have the time to wait for return of sperm to ejaculation, then sperm retrieval for assisted reproduction is your other option. The costs are much more than vasectomy reversal, and this comes with a higher risk of birth defects and pregnancy complications. Now, sperm quality is also affected by vasectomy. There may be sperm absorption by the endothelial cells, which stimulates the immune system and production of anti-sperm antibodies. These are found in more than 60% of patients that had vasectomy 6 to 8 weeks post-op. The anti-sperm antibodies affect sperm motility, penetration of the cervical mucus, binding of sperm to zona pellucida, and sperm egg fusion. There is decreased rate of pregnancy after vasectomy reversal. The World Health Organization says about 15 to 30% of male infertility may be immune related, and anti-sperm antibodies may be part of that. Now, there is injury to the sperm itself. This seems to be related to the time since vasectomy, and this includes increased DNA fragmentation, decreased count and motility, increased apoptosis, and increased abnormal sperms. This paper from 2019 Urology Journal was looking at litigation when it comes to vasectomy procedures. And the pie chart is showing the reason for litigation and the claimed breach of duties. About 37% of the claims was on negligence in post-operative care. And that was followed by negligence in surgical performance. And lastly, negligence in informed consent. The table just shows average payment per breach of duty or damage. And just a case of interest is that in terms of surgical performance, that was the group where there was the highest number of cases decided against physicians. And the highest payment also came from that group, and it was $1.2 million US, where a surgeon had tied and cut the testicular artery instead of the vas. Now, to avoid running into trouble with litigation and to practice vasectomy as it should be done, one should be counseling their patients in person. This preferably should be done sometime before the procedure. That counseling session also affords the surgeon a time of physical examination, where one would be looking whether the vas is palpable, whether the patient has accessory vas. One has to make sure that there are no testicular lesions in case the patient would benefit rather from an orchidectomy. Now, at that counseling, you need to assess the patient's contraceptive needs. You need to discuss alternative methods in patients who may desire fertility later. It is important to emphasize that vasectomy is a permanent procedure. You need to emphasize the cost and success rates of vasectomy reversals. And consent by a partner is not necessary, but if your patient is in a committed relationship of sorts and the partner is available, counseling should happen with the patient and the partner present, if possible. Then you need to discuss your surgical techniques with the patient. You need to tailor this to individual patient. Dr. Hussein has already touched on different surgical techniques. And then you would need to discuss whether this will be done under local anesthesia or a general anesthesia. Then you need to discuss the risks and the specific complications that are associated with vasectomy. And most importantly, you need to discuss post-vasectomy care with your patients. The literature shows that there's about 50% compliance with post-vasectomy semen analysis. And this is very important because patients need to use other temporary contraceptives until post-vasectomy semen analysis confirms sterility. This is usually done around 3 months or about 12 weeks. And sterility then is confirmed by azoospermia or rare non-motile sperms less than 100,000. In conclusion, vasectomy is a permanent surgical contraceptive method for men who do not want children. And this is a view of the South African National Department of Health, the American Urological Association, the European Urological Association, and in their recent guidelines, French Urological Association as well. You must discuss alternative methods with patients intending on having children later. This is also a recommendation that came out of the National Contraception Clinical Guidelines of the South African Department of Health. AUA recommends that number of children and age of patient be considered in decision-making. And the EAU says that being less than 30, not having children, being single at the time of consultation, relative contraindications to doing a vasectomy. This is all done so that one limits the number of vasectomy regrets once the procedure has been done. The number of vasectomies in the developed world are decreasing, as noted from a study that came out of the UK. And that would mean that the 6% of the vasectomy regret is decreasing with that. And that would mean the number of vasectomy reversals would also decrease. And that means the volumes for surgeons would decrease. And we know that that is one of the drivers of success. These are my references. And that's it. Thanks, Dr. Apple.
Thank you very much, Dr. Chacha, for your talk. We're going to ask Dr. Mahadhi to comment or offer a rebuttal for that. Afterwards, you can also do that, Dr. Chacha.
Hello, can you hear me?
Yes, we can, Dr. Mahadhi. You can make it full screen.
Okay, let's see the misconceptions around the vasectomy reversal. So there's two misunderstandings. There are about two misunderstandings about the success rate and the timing of the success, as well as the Dr. Chacha, he mentioned about the vasectomy complication. To start with the vasectomy complication, post-op complication, which is hematoma or infection. If you read the AUA guideline, now they recommend the no-scalp vasectomy, which has less complication compared to the conventional method. But I brought this article here. This study was done very long, more than 30 years ago. These guys, they did a lot of study about the vasectomy reversal. Since then, we found there was good patency rate and good pregnancy rate, regardless of the technology 30 years compared to the current technology, but still the reversal showed success, and the patency was good and the pregnancy rate was also good. And another study which was done by, this was Gerard and his colleagues. This is another misconception about the failed vasectomy reversal. Can we repeat the vasectomy reversal or not? And then in the summary of those two articles, the one which was done by the Belka and his colleagues, you can find the patency was very high, about 86%. Even with repeated vasectomy, still have significant 75% of patency and 43% of pregnancy. So this debate has been long, more than 30 years. And the reversal is not something new. It has been done more than 30 years. So now, I think there's no reason for not doing this vasectomy reversal. And if it can be done in a successful way in the microsurgical technique, then vasectomy can be considered as temporary contraceptive method. Thank you.
Thank you, Dr. Mahadhi. Dr. Chacha, do you have any comment?
Thank you, Dr. Mahadhi. Thank you, Dr. Opel. The issue of success rate for vasectomy reversal, the numbers could be impressive if one looks at them at face value, but as I said, there's the different researchers define it differently. For some of them, one motile sperm present in the ejaculate is a successful reversal of vasectomy. And as a procedure, vasovasostomies and vasoepididymostomies, if they are done for as treatment for male infertility, they are great. But if you're doing it post a vasectomy, one must also actually be looking at it as loss of fertility, to say that if I do a vasectomy for you, you could be in the 20% that their fertility that lose their fertility permanently. So I think that's how we should be speaking to our patients when we are presenting these numbers. The other thing that I'm curious about, and maybe Dr. Mahadhi could help us, is that when you do offer it as a temporary form of contraception, once you've done the reversal and your patient is one of the lucky ones where it actually became successful, once they've had the number of children that they want after that, what then becomes the mode of contraception going forward? And just lastly, on the infection, I think even at 2%, which is a quoted number most of the times in vasectomy literature, I think it is something still that one needs to be concerned about, especially considering that it could lead to devastating Fournier's gangrene.
All right. Thank you for that, Dr. Chacha. Okay, we're going to move on to questions from the audience or from the chat. If anybody's got any comments. Dr. Mahadhi, I just want with your talk, those first two slides you mentioned, and I think you both alluded to this, is that although reversal as whether it be micro or macro surgical or even robotic assisted, has good patency success rates. I think the pregnancy rates afterwards are quite poor. So I think, as Dr. Chacha said, counseling is extremely important. A question for Dr. Mahadhi. In a patient that had a vasectomy that's never fathered any children and now wants a reversal, is it reasonable to sort of first do a testes biopsy prior to doing that, or can you offer them a reversal sort of upfront?
Hello, can you hear me?
Yes, we can hear you.
Before going to the operation, as part as a AU guideline, they recommend proper history taking and physical examination. And if there is any suspicious of the pathology, then it is not indicated. If you have previous epididymitis with complications, or even if the partner, the female partner, they should be examined and then to see if there is something which can contraindicate there. But there is no any place I found that they need it to do testicular biopsy. But I haven't come across with that one. But it is part of, before going, we need to do proper history taking and physical examination for both male and female. Thank you.
Thank you, Dr. Mahadhi. And then Dr. Chacha, in your talk, you spoke about extra ways or other ways of contraception. Do you have any, can you give us any further information on that? I know there's papers coming out of the US on a male oral contraceptive pill, which is temporary. Are you aware of anything else?
Hi, Dr. Opel. Just wanna. So there is a couple of studies that are looking at different options that I on my slides. The one is the pill, and they are also looking at injectables. And there's another study that is looking at a combination of testosterone and nosterone gel. So there's quite a few of them that are currently underway.
Yes, that's correct. I mean, the one from the US, I was talking about a non-hormonal medication. I'm not exactly sure the mechanism of action, but tested on mice, active within an hour, and the effect lasts for about 3-4 hours. So it's a on-demand sort of male oral contraceptive, which looks quite promising. Do we have any other further questions or comments? Unfortunately, this morning we are unable to put up a poll. I don't think we have all the hosting power here, unfortunately. So if there aren't any other further questions from the chat, I would deem both of you winners. You both argued your points quite well and presented nice and engaging talks for us this morning. So I'd just like to thank both speakers for their presentations. I think we are a bit under time, which is always better than being overtime. So I'm going to thank you guys again and wish everybody a great weekend and weekend. And we look forward to hearing from everybody next week again. Thank you.